dara-CyBorD, which is a combination of cytoxan, bortezomib, and dex, is widely used in the U.S. community centers as an induction treatment for frontline treatment of our patients with multiple myeloma. And we have the first-line data from Europe, adding daratumumab to VMP improved progression-free survival. So, but melphalan is not used in the US that much, so we want to see if we add dara to CyBorD, which is a commonly used regimen, can we improve outcome in this patient? That's kind of the background why we did this study. It was a phase 2 study, single-arm study, enrolling 101 patients. 87 patients were newly diagnosed, and we had a small number of patients who were first relapse multiple myeloma patient, and that arm was closed early because of poor accrual. So we're going to we will focus on the newly diagnosed patient when we go through the results. So what we found is when we look at the primary endpoint of the study is VGPR, very good partial response or better, after 4 cycles of induction treatment, and there are other secondary endpoints which includes progression-free survival, overall survival. So the VGPR or better after 4 cycles of induction was about 44%, and with an overall response rate of 79% in the newly diagnosed multiple myeloma patients. With a longer follow-up, 18-month progression-free survival was about 79% in all comers, but when we look closely at the non-transplant multiple myeloma patients, it was 78%, which is similar or slightly better than the daratumumab VMP study in the Alzheimer's trial from Europe. Dara is now being combined with RVD, which seems to be a better backbone regimen, but not all patients with newly diagnosed multiple myeloma are able to receive Revlimid treatment. So I think our study, which shows a favorable progression-free survival, will have a role in treating this patient, especially if they are not a candidate for Revlimid-based treatment, if they present with renal failure, or if they can't tolerate it. I think that would be where I will use it.